Welcome back to our channel. Today we are going to look at lower back pain. This is a common problem in the population. It cuts across from the young people to elderly people. The most common cause of lower back pain in young people is posture. You know, the way they sit. I've seen several. When they sit curling up like a ball, watching TV with a remote on one side, that position strains the structures in the lower back and they end up with back pain. In elderly patients, the most common cause of lower back pain is osteoarthritis. Osteoarthritis is a degenerative process which damages joints, specifically not only on the vertebra but also on the facet joints. Facet joints, just like the knee joint, they also get wear and tear, and one ends up with osteoarthritis, osteophytes growing, and movement causes pain. And in facet joint osteoarthritis, some patients may also have radiating pain. So another cause of lower back pain is sciatica. Some people call it lumbago sciatica. It used to be called that way, but most people refer to it as sciatica. And sciatica, this is a radiculopathy whereby a patient has pain on one side and it radiates to the buttock or the thigh or even in the leg or foot. We'll come back and discuss further on sciatica, because many people present with sciatica, and like I've seen, it is not only occurring in elderly patients but also in young patients. Some of the other causes of lower back pain may include infections, and infections can be bacterial, like a bacteria causing infection and therefore causing pus around the back. And it may also be mycobacterium. Mycobacterium is common on the upper back, but like I say, diseases don't read books. Sometimes you may find it occurring in the lower back and causing cold abscess, which may be accompanied by many other things. Bone pathologies may also present with lower back pain. Now, there are several of them, and they include infection of the vertebra. The vertebra, just like any other bones, the long bones or the metaphyseal bones, they also get infected, and when they are infected with bacteria, this is called as vertebral osteomyelitis. So it can equally cause pain. Sometimes tumors of the vertebra, can also present with pain in the lower back. And an example is multiple myeloma. Multiple myeloma is the most common primary bone tumor, which may also present with back pain, like we have said. It has a predilection for the vertebra and other bones which have soft bone, trabecular bone. If you have a tumor growing nearby, it may also cause confusion and present with lower back pain, and therefore, like we said, investigation may help you to delineate, to differentiate from all these other possible causes of lower back pain, so that you can pinpoint on one. We'll come to investigations later. Other causes of lower back pain may be deferred pain. Sometimes people have a problem with the pancreas or the kidney, and that pain, the patient reports that it comes from the back, but actually the problem is in those organs. So we should remember the possible organs that may have a pathology that may present with lower back pain. By the way, I'm forgetting ladies, some of them who may be in their 30s or early 40s, who may have developed cancer of the cervix, may also report lower back pain, a form of referred pain. Degeneration of the interspinous ligaments, those ligaments which connect the spinous processes in the back, sometimes they tear. And when they tear, they also lead to lower back pain. And if you don't remember that is a possible cause of lower back pain, then it means you may miss it, unless a good radiologist picks it and therefore reports it to you. So remember the interspinous ligaments, they may also be a source of lower back pain. Now, muscles of the back may also be injured and lead to lower back pain. Specifically the multifidus muscle, which is so close to the vertebra. Sometimes it gets injured or traumatized, and it may also present with pain. And by the way, in some patients, they may develop a sensitive spot, once it develops, and when pain starts there, it spreads to the rest of the muscle. So those are the possible causes of lower back pain that are there, and there are many others I have not mentioned. So when one is handling a patient with lower back pain, should remember them and investigate along those lines to pick one of those. Specifically, I want to come back and discuss sciatica. Some people may call it lumbago sciatica, but that is an old way of referring to that pathology. So many people refer to it as sciatica. Now, sciatica is a form of radiculopathy, whereby there is lower back pain which develops in a patient, and it radiates to one side. Usually it is unilateral, so it can be in the buttock, it can be in the thigh, or it can radiate to the lower limb or the leg. Occasionally bilateral, and when it occurs bilaterally, then there is what we call as complication of the same, called equina. Now, risk factors for sciatica may include one, age. As one ages, also the posterior ligament may age and tear off. Most of the patients start reporting about symptoms of sciatica as they grow old. So age is an important factor, and it relates to degeneration. Another risk factor is obesity. Obesity strains the back, and therefore predisposing the patient to tearing of the posterior ligament, leading to sciatica. Another condition we may predispose to sciatica is diabetes. Diabetes as a condition by its own increases the risk of injury to the nerves and also presentation with sciatica. Now, occupation is also an important factor. Occupation, depending on what one does, especially masons, carpenters, mechanics, people who dig manually, when one keeps on twisting the back as they work, or those who sit for too long, like secretaries in the office, or long distance drivers, those people may be at risk of developing sciatica. So usually what happens in the pathophysiology is that there's that small structure which is between the vertebra in the back. So they are called as intervertebral discs. The intervertebral discs are made of two parts: the nucleus fibrosus, the outer ring, and the inner nucleus, which is called as the nucleus pulposus. So in sciatica, what actually happens is that the nucleus pulposus, the nucleus fibrosus tears. Yeah, it tears off, and the nucleus pulposus now protrudes or is extruded into the canal, and therefore impinging on the nerves which are transcending or descending. So that leads to the symptomatology that patients talk about. There are many classifications, but we have locational classification, where you have like central protrusion just in the midline in the back. There will be protrusion. One, you will get the nucleus fibrosus tearing, and then the nucleus pulposus protruding through or getting extruded, and therefore causing lower back pain. So this lower back pain usually is not radiating to any side, like the left or right buttock. No, the patient will just be reporting of lower back pain, which is maybe chronic, it has been there for a while. Then you have posterior lateral, and this is the most common. And the reason why this occurs is because in the posterior ligament, this is the weakest point anatomically, where it tears, and then the nucleus pulposus will extrude or protrude or even get sequestered. So the posterior lateral is the most common type of injury that occurs in the nucleus fibrosis, leading to protrusion. Now we have the foramino or the far lateral. Foramino and the far lateral. Now this one causes actually compression of the exiting nerve roots and the upper roots, whereas in the posterior lateral you have the transcending, the descending, and the lower nerve roots being impinged when it occurs, and they radiate to one side most of the time. And then you have the axillary type, which causes compression of both the exiting and descending nerve roots. You may also have morphological classification, like we talk of extrusion, where the nucleus fibrosus is torn, and the nucleus pulposus just peeps out. There is continuity between the outside part and the inner part, so there is some form of continuity. Then we have the extrusion, protrusion, whereby the disc, the nucleus fibrosus tears, the nucleus pulposus gets out, and there is no continuity. And then sequestration, where the nucleus pulposus gets out completely and falls into the canal, where it causes symptomatology or pain, depending on which nerves are pressed on. Now, when a patient comes with complaints of the lower back pain, and we are thinking he or she could be having lumbar sciatica or just sciatica, then you should investigate the patient. Take good history. Good history will help you to know which type, like the locational type. If the patient has been having constant lower back pain, which is not radiating, then that would be a central type of sciatica. If it is radiating to one side, it's possible also to know whether it is posterior lateral or foramino or even axillary. So good history. Then come to physical examination. Of course, you are going to examine the patient generally, that is the whole body, and then you concentrate specifically on the lower limbs. You will palpate when the patient is lying prone, so that you are able to elicit tenderness or any swelling around the back. And then while the patient is seated or even lying supine, that is on the back, then we do the straight leg raise test, the LASIK sign. Now, at around 30 to 70 degrees, if the patient feels pain, then it means the straight leg raise test is positive. This can also be predictive for patients who may benefit from surgery, like the ones who develop a positive straight leg raise test. It means that they can benefit from surgery if it is done within 2 months from the time of onset of the symptoms. So from research, it has been indicated that those who have negative straight leg raise test, they do not benefit from surgery. And by the way, in the management of this condition, most patients will benefit from conservative management, that is non-surgical. So we'll come back to that later. So when you've done the straight leg raise test while the patient is lying supine, you may also do the cross leg, which is more sensitive than the single or unilateral leg. Then also elicit the dermatomes, for you to know which level the patient could be having disc protrusion. Now, if the patient is unable to abduct the thigh and extend it, if there is weakness, then it means it is at L3 level. The nerve root there is L3 level. If the patient is not able to walk on the heels, you can ask the patient to walk on the heels or on the heel, depending on the affected side, to dorsiflex the ankle joint. So the patient is not able to walk on the heel on the affected side, and then when you do a deep tendon reflex on the patella, you find it weak, and then there is a lack of sensation, or there is a lot of pain on the anteromedial side of the thigh, then that means this could be at the L4 level. So L4 nerve root will be affected. If you ask the patient to walk on the toes on the affected side and it's difficult, or you tell her to walk on the toes 10 times and she's not able to do that, and you find the pain is on the anterolateral side of the leg and on the dorsum of the foot, then most likely the affected level is L5. L5. Now, again, L5 can also present, a patient can present also with weakness in the hip on abduction. You can also ask the patient to lie on the side and then to elevate or lift the leg, the affected leg, up against gravity. So those who are affected most of the time are unable, or they do it with difficulty. So that is all. And okay, there are other investigations you can do when you are examining, but the most commonly used are the ones that I have just mentioned. You can also go further and do investigations to confirm or rule out the other differentials. So here you may need a plain X-ray, or lumbar sacral plain X-ray. This one will help you to focus on the bony structures where you might pick osteophytes or any bony prominences which may be pressing on the nerves. And then you will be able to see loss of lumbar lordosis most of the time, because muscles are in spasm because of the pain that is there or around there. So the lordosis that you usually see in a normal patient will be lost. So you might have a straight lumbar area abnormally. Sometimes you might also see bone changes, like in bone tumors. If the patient has bone tumor, like in multiple myeloma, we said you might see the punched out lesions. So those ones are the ones you see on a plain X-ray. Then you may do CT, a plain CT. Most centers have CTs, so you can do a plain CT of the lumbar area. Sometimes people may have pacemakers who may not be able to go for MRI. So we also do CT scan. Actually, CT myelogram will be recommended. So it improves the sensitivity of the CT scan in picking up what is affecting the nerves. Then you can also do MRI, a normal MRI. But with the patients who have metal or metallic devices in the body, you know, there have been orthopedic patients before. They might be having implants in their bodies, which were used to maybe reconstruct the bones, or cardiac patients who may have pacemakers. You know, those ones you don't send them to the MRI because it might be catastrophic. So for that reason, you send them for CT myelogram, like we just said. But those without those contraindications, you send them for MRI. So MRI will show you the levels that have been affected. Most of the time, it is at L4, L5, and L5S1. Yeah, but like we say, diseases don't read books, so they might present at a different level. So it's good to investigate so that you are able to confirm scientifically and say this level is the one which is affected and how severely it is affected. MRI will also help you to know whether you really need to go in and do surgery. Yeah. So you can also do the basic investigations, the baseline, like a full hemogram. You know, you need to see HB. You know, people who may have tumors, like we keep on saying, the multiple myeloma, their HB will be low, to be around 6 or even 5. Most of the time severely 4, 5, around there. So it is necessary to do a full hemogram to help you not only in the management, because even if you want to give that patient chemotherapy, you cannot administer it when the HB is lower than 10. So it is necessary to do that. And platelets, you need to see them, and they have to be within normal. So if you don't do a full hemogram, there's no way you're going to know that the platelets are within normal. These are surgical patients that you might take in for surgery. So when the platelets are low, like as low as 100, you have a risk of bleeding intra-op. And some patients may bleed, they end up in shock or acute renal failure, and this can be an issue of deterioration. So it is good that you are on the safe side by investigating your patients well. Do other baseline investigations like liver function tests, kidney function tests, rule out all the other comorbidities, diabetes, hypertension, and all that. MRI with the gadolinium will also improve in the sensitivity, but some centers may not have it. As we are in a developing country, not every center has the privilege of having those machines. So we go basic most of the time. So once you have investigated, if you have ruled out the other differentials that we mentioned, there are several of them, we move to treatment. And the treatment of sciatica most of the time is conservative, and if it is occurring for the very first time, that is like in less than 6 months, we call that as acute. And if it has happened start the patient on drugs that they are going to help the patient. By the way, the pain that is caused by sciatica is both mechanical and inflammatory. So if you give the patients NSAIDs and steroid or anti-inflammatory drugs, they are going to remove or do away with the inflammation. You see, the inflammation which comes about due to the compression produces cytokines like tumor necrosis factor alpha, like the MMP, the NO, like the prostaglandin 2, like the interleukin 6. All these causes inflammation. So if you're going to give non-steroidal anti-inflammatory drugs, and I'll give an example of like etoflam. Etoflam we give 120 milligrams per oral OD, maybe for 10 days for a start. But if this patient could be having osteoarthritis, then you give it for 1 month. And an addition you can make when it is occurring acutely is you can also give steroids. Steroids really do well. They reduce the inflammation just like the non-steroidal anti-inflammatory drugs. So when you combine them, the benefits are higher than when you use a single one. So maybe use of methylprednisolone, maybe 60 milligrams OD for a short time, and you taper it down. It will help. But also make sure that you know your patient well, because diabetics should not be given steroids. Steroids are going to increase the sugar levels and they disorder the control. After that, then you modify the lifestyle of the patient. You see, we said some occupations predispose patients to sciatica. So one who has developed sciatica or has shown symptoms of sciatica, we will tell them to modify their lifestyle so that we go the conservative way as they are taking the drugs that we give them. We also tell them to modify their lifestyles. Those who are lifting heavy things, they should stop. Masons who lift blocks or mechanics who lift engines, car engines, they should stop for at least 6 months to give the tissues time to heal. So they should not lift anything more than 5 kgs and above. Even if it is water for bathing, people still bathe, using, some even go to the river to bathe there. So we don't want them to bend. So when they are bathing, they should not bend. They should bathe while standing, or someone can wash them, clean them up. And even if they are the ones who are going to prepare the water for bathing, they should not carry the old 20 liters. They should carry like 3 liters, keep pouring until it is enough. And then they should use now a table or a stool which is raised, so that it enables them to shower, to bathe while standing. Especially those who have no shower roses. But those ones who are able to shower, they can use the shower, and it will prevent them from bending. So they should also not draw water from the well. They should not go to the garden to dig. They should not even go plucking vegetables, because it will require that they bend. Even tying a shoelace, they should not do that. Let someone else do that for them, so that they can heal. Otherwise, they will continue having the symptoms, and sometimes it is intolerable. Then, when they go to sleep, they should lie on their back. You lie supine with a pillow behind the neck, behind the lower back, another one below behind the knees, so that it relaxes the sciatic nerve and of course the cord, and so the person feels better. So most of the time that's the position they should sleep. But occasionally, because one gets tired, you can also sleep on the side. Other drugs that can be added to help include antidepressants, and I prefer the use of amitriptyline. If one is able to tolerate 50 milligrams nocturne, it will really help. One, it will put the patient to sleep, and also manage the peripheral neuropathy. So it is a two-pronged therapy, which will help the patient. Use of nerve pacifiers may also help, like Pronav or pregabalin, 75 milligrams. Can do OD oral for maybe a month, and there are others. So those are drugs that can be added so that they help the patient quickly. Another modification for women, actually the ones who may be sexually active, is to avoid bend over. There's a style they call as bend over, because it is just like bending to pick something. So it opens up the vertebra, and the nucleus pulposus can easily pop out and cause problems. So for 3 months, we tell them not to assume that position. The other one that everyone can do, whether male or female, is that they should employ ergometric measures when lifting things. You don't just bend like a bow and lift something up. Let your legs do the lifting. You squat, you go down while you maintain your back straight up, and from the side you grab whatever you want to lift and go up straight. So the legs are the ones lifting, not the back. And sometimes you may need to be taught for you to understand that method. So that is something else that should be done for the patients, so that they don't go back with a painful experience. Exercises can also be done to augment this treatment, and actually the exercise should be for the future to prevent reoccurrence, and this is to strengthen the core muscles, like the abdominal muscles and also the back muscles, so that you can also increase range of motion and strengthen the ligaments around, so that there is no tearing in the future. So some patients have come back saying that when they go for exercises, when they have acute pain due to sciatica, that it worsens or they don't get any benefit. So I would recommend that we treat their current symptoms first. Once this pain has gone away, then we start the strengthening exercises for the core muscles, so that there are those, if you send them when they have acute pain to physiotherapy and they go through a lot of pain, they will not go back again for another session. So 90% of patients benefit from what we have just said, conservative management without any surgical intervention. But there are those few, the 10%, maybe God has said that we must operate, or the non-compliant patients, those that we tell follow this, do this, and they don't. So those ones we finally operate on them, plus those who develop Cauda-Equina syndrome. At some point I mentioned Cauda-Equina syndrome. Cauda-Equina syndrome is where one develops acute sciatica. It can also be chronic, that is after 6 months, but they present with the following: the painful legs bilaterally. You can also have weakness in both legs, or you can have lack of control of the bowels or lack of control of the bladder. That means the patient can either retain urine or feces, or they can pass them out without any control. So those are the bowel and bladder movement problems. If you see a patient with a history of sciatica and he has developed that, that is an indication for emergent surgery for decompression. So the 10% patients may include those. So we take them in for surgery, and the kind of surgery that usually is done is laminectomy and microdiscectomy. Now this involves opening, it can be done open, as in like we do most of the time in the third world countries, but in other centers they can also do arthroscopic microdiscectomy. Yeah, make a small hole, use cameras and machines. We have the arthroscopic tower. We get in there and they remove the offending disc, the one which is pressing on the nerves. But the open type is where you will open the back some few centimeters, up to 8. Delineate, remove the muscles to the side, then remove the spinous processes, then remove the lamina, push the spinal cord nerves aside, and then go for the intervertebral disc. You will just see it in there. You remove it and clear it completely, then clear up and close up the patient. So that is called as laminectomy and microdiscectomy. But in some centers where they have the equipment and the skill, they can still do the arthroscopic type. So 50% of the patients will benefit from this surgery, but another 50 will be unfortunate because their pain may not go away. So we have some of the complications which are associated with this kind of surgery. One of them is dural tear. Dural tear, that is where when you are going in, inadvertently you tear or rupture the dural membrane, and so there is leakage of CSF. So you end up either repairing or referring to the neurosurgeon to take care of that. You see, CSF leakages usually lead to chronic headaches, and so patients may be complaining of headache after this surgery. Yeah, so always prevent the tear of the dura, but it can happen even when you are very careful. So this is a known complication which is associated with this surgery. Another one is epidural fibrosis, where you are going through, maybe blood may be forming in there, and then it heals with fibrosis. And then you may have recurrence of the symptoms in the patient. After a few months of surgery, the patient comes up with the same or similar symptoms like the ones that brought her to you, and you made that diagnosis of sciatica. Yeah, so this may require going back again and redoing the whole procedure. Infection of the wound can also occur, and sometimes you may have pyogenic discarded. So when pus forms, you may need to go in, do incision and drainage, clean up the area, apply the required or antibiotics or drugs, and then the patient will heal. There are other complications which may come up, but they happen invariably, actually variably, as in what I'm just mentioning does not happen in every surgery. People are different. So some people may develop what we have said, and some people may never develop any of those. So it depends on maybe what God decides, or how unfortunate the patient is to develop those complications. Like we say, it's no surgery without a possible complication. Yeah. So thank you very much.